Hello everyone, welcome back to the surgical canvas. Today we will be discussing radiation and radiation injury in cases of plastic surgery practice. Here we will quickly revise the conditions which a plastic surgeon encounters in cases of his day-to-day life. So let's start with the radiation. What does radiation do? Radiation creates reactive oxygen species which are self-perpetuating. It means that even after the radiation dose has been given, the reactive oxygen species are being formed and are causing repeated damage to the tissue. Moreover, there is direct DNA strand fracture and there is sclerosis of the capillary network which leads to the hypoxic environment. Overall, the radiation causes profibrotic inflammatory milieu which is irreversible, delayed wound healing and increased risk of infection. Now let's deal with the conditions which a plastic surgeon have to remember in all patients of the radiation injury or all the patients which are going to have radiation therapy. For example, in cases of oncoplastic breast reconstruction, in cases we have seen there is equal survival in cases of breast conservation surgery compared to the total mastectomy. Even new studies have found that the breast conservation surgery has superior outcomes. So, in all cases of breast conservation surgery, we have to go for neoadjuvant chemotherapy. Therefore, reconstructive surgeon should consider changes to breast following radiation. So, we have to also consider for the contralateral procedure to maintain symmetry, and timing of the contralateral procedure has also to be taken care of. Now coming to the mastectomy reconstruction, most of the centers follow two methods for the mastectomy reconstruction. The first is the two-stage approach. Here in the first stage we go for tissue expander at time of mastectomy, and after 6 months we go for the implant, and the other method is direct to implant. Both approaches are safe and effective. These approaches are done when there is no history of previous radiation therapy. But if there is case of prior radiation, higher risk of complication with prosthesis backed reconstruction has been identified. So here many centers perform autologous reconstruction because there are complications of implants which increases in case of radiation therapy. For example, infection, wound adhesions, implant loss and capsular contracture. Here we can avoid all these things by making a pedicled latissimus dorsi flap. This also provides vascularized tissue cover to the device. We can confirm that the autologous approaches there is 95% success at the high volume centers, but still there is risk of flap loss which have to be explained to the patient properly. Moreover, in case of a free flap which is being planned in patient with previous history of radiotherapy, we have to wait for at least 6 months. Then only we can proceed with the free flap surgery for reconstruction. Now coming to the breast cancer related lymphedema. Axillary lymph node dissections, Taxol based chemotherapy and radiation all causes increased lymphedema risk, which is approximately 23 to 54% in different studies. For management of lymphedema, we can go for therapeutic purpose when lymphedema has developed, and if lymphedema has developed in cases of therapeutic purpose, there is well documented evidence that it has good outcomes. And for prophylactic approach where lymphedema has not developed but we are thinking about the lymphedema surgery, earlier studies have shown a promising outcome, but the clear-cut evidence is still missing. Now coming to the head and neck reconstruction. Radiation injury can cause osteoradionecrosis as well as it can cause post-operative speaking and swallowing function disorders, as well as it can cause destruction to the salivary gland and lacrimal gland. Osteoradionecrosis, which can develop in any bony structures where the radiation therapy dose is more than 60 grays. And the management of osteoradionecrosis is aggressive debridement until we see fresh bleeding and reconstruction with vascularized tissue. Let's discuss few examples. For example, osteoradionecrosis of the calvaria. Here we have to go for synthetic calvaria or titanium implant for calvarial defect, as well as we have to go for free flap to cover the soft tissue defect. So two procedures has to be done. In case of osteoradionecrosis of the mandible, we have to go for segmental mandibulectomy with reconstruction with vascularized bone flaps. For example, free fibula osteocutaneous flaps. Now, in all cases of reconstruction where the patient will be going for radiation therapy, we have to always go for overcorrection, because after radiation therapy there is volume loss of up to 30 to 40%. So we have to plan accordingly and we have to go for overcorrection. Now coming for the sarcoma reconstruction, there are few cases of radiation induced sarcoma, and in those cases there is higher risk for impaired wound healing, as well as there is increased risk of infection. Preventive lymphatic reconstruction following tumor removal, as many sarcoma often receive neoadjuvant radiation therapy. So in cases of sarcoma, many of the time we can directly go for the preventive lymphatic reconstruction. Now coming to the treatment of radiation injuries. Several studies have found that antioxidant deferoxamine, tocopherol, pentoxifylline, clodronate has been useful in osteoradionecrosis as well as other radiation induced injuries. Thank you.